intra-extraventricular tumors. So the radicality of our removal is shown on this picture. So you see the majority of the tumors were removed gross total and subtotal removal. Some of them partial, endonasal endoscopic cyst aspiration, and Omae reservoir. So these are the examples of that which we describe as a total removal or gross total removal. So these are the cases with no visible remnants on MRI, performed 24-48 hours after surgery. This is the total removal for the endosuprasellar tumors, for the pituitary stalk tumors, and pay attention that the floor of the third ventricle is preserved in this case, and the third ventricle tumors, and in this case the pituitary, the ventricle floor is damaged. So the subtotal removal we define when we see the flat remnants of capsula less than half a square centimeter in diameter. And so these are the examples for the endosuprasellar tumors in the remnants in the cellar. For the pituitary stalk tumors, this is the suprasellar remnants near the brainstem. And this is for the third ventricle tumors, the remnants in the region of the ventricle floor. And the partial removal, when the volumetric 3D part of the tumor, which may be estimated its size. So this is for the endosuprasellar tumors. This is for the pituitary stalk tumors. These are the remnants in the region of the pituitary, of the third ventricle floor. And this is for the third ventricle intra-extraventricular tumors. In this case, it was operated with the help of the transcallosal approach, and the basal part of the tumor stayed unremoved. So, and then we have tried to investigate the factors which influencing the prognosis. So, the radicality of tumor removal. So, the size of tumor remnants does not influence the prognosis. So, we have investigated several types of, several grades of radicality, and it appeared that the only one significant factor is the gross total removal. This is the red line on the Kaplan-Meier scheme. So primary versus secondary surgery. We have revealed that primary surgery has significantly better survival. Perhaps it is due to more radical removal of the tumor. So this is the blue line on this scheme. So the localization of a tumor has no influence on the recurrence-free survival. But there is no significant difference due to the approach, but nevertheless, the survival with transcranial approach in cases of the endosuprasellar tumors is worse. Maybe it is due to less visualization of the endocellular region when we perform the subfrontal or pterional approach. So, of course, these tumors are perhaps better to treat with the transnasal approach. So, despite the absence of significant difference, we see much more rapid relapses in cases with endocellular remnants. So, it means that thorough follow-up is indicated in order to start the adjuvant radiotherapy in time. And now about the radiation therapy. So in our center, we have all types of stereotactic radiotherapy and radiosurgery, which include lean accelerator, cyber knife, gamma knife, except proton therapy. but it is available in Moscow in another center now. So, and I think this is the most important slide in my presentation. So we obtained the exactly equal results of gross total removal of a craniopharyngioма and non-total plus radiotherapy. You see, the results are equal for these two groups of patients. So it's very important. So when we have obtained such results, we have searched the literature and revealed several meta-analyses which have the same results. For example, on the first table, this is the large meta-analysis which include more than 400 patients. And you see that the gross total removal and subtotal removal plus radiotherapy have nearly the equal results, even in the 5 or 10 year follow-up period. And the bottom table shows only the pediatric craniopharyngioma with more than 100 patients. And you see the same result. So the gross total removal and subtotal removal plus radiotherapy has nearly the same results, except the subtotal removal alone. So these results are much worse. And the same results are in our series. You see this blue line, this is the subtotal and partial removal of craniopharyngioma. You see that the results are very bad, but the radiation therapy plays a great role and it greatly improves the recurrent-free survival rate. Now, this is the question. So, when to start the radiation therapy? To wait or not to wait the recurrence, or to perform the radiotherapy in all cases just after surgery with non-gross total results. So, and again, we have compared these two groups of patients, and you see that the results of the adjuvant and salvage radiotherapy are equal on the left scheme. So immediately after primary surgery may be a bit better, but not statistically significant. Now about morbidity and quality of life. So the hormone deficit. So due to preservation of endocrine functions, the following grades of radicality appear to be significant. So the gross total, the non-total, and aspiration. The higher radicality, the higher hormone deficit. You see on this scheme, all the basic hormones are shown. So hormone deficit increase after surgery to the same extent in all types of tumors due to their localization. But you may see that the initial state is much worse in the endosuprasellar tumors. Thus, the final results will be worse. So, and this is very important. Again, this is a very important slide because we have compared the hormone deficit after surgery and then after radiation therapy. So, and we analyzed only the patients with partial hormone deficit after the primary surgery, not the panhypopituitarism, otherwise it's no reason to compare these two groups. So, and you see that there is a minor deterioration of a hormone state after radiation therapy. So, except ACTH, so, but at a very small extent. And now another group of functions, which means that I speak about the diencephalic functions. Please don't mix them with the hormone deficit. This is quite different different pathologies. So the body mass index, the BMI index, may be a marker of the diencephalic damage. So, and it is much higher in patients with gross total removal. You see, this is the red line in this table, and you see that this BMI index, body mass index, which reflects the weight gain, so it is much more higher than in the total removal than in the partial or aspiration. Now, what is about the preservation of diencephalic functions due to the localization of the tumor? Yes, the BMI index correlates with localization. It is much higher in patients with third ventricular craniopharyngiomas. If you remember my first slides in this presentation, which I have shown our classification of craniopharyngiomas, you will realize that it is really so, because the endosuprasellar craniopharyngiomas are not so close to the diencephalic region, and if it is a rich diencephalic region, it will only displace it, but not infiltrate in the majority of cases. And this is also a very important item. So, very interesting fact that the damage effect of radiation therapy appears in 5 years after treatment, not immediately. So, another very important parameter is the visual functions. So, the deterioration of visual functions, this is after surgery and after combined therapy, and you see this, that after combined therapy, the deterioration of visual functions is very limited, only about 6%. And now this is the cumulative investigation. This is the quality of life, which we performed with 2 different scales, the pedweb2 and DeVille. So, and you see that the patients with primary non-total surgery plus radiotherapy has better quality of life. So, to conclude this part of my speech, so we advocate the treatment of craniopharyngiomas according to the degree of the hypothalamic involvement estimated by localization of a tumor and confirmed at surgery. So the total removal in cases of endosuprasellar and suprasellar craniopharyngiomas with the absence of hypothalamic involvement, and subtotal with adjuvant radiotherapy in intra-extraventricular craniopharyngiomas and other types with no intraoperative differentiation of hypothalamus. So, and we have the third method of treatment of craniopharyngiomas. This is the aspiration with administration of some drugs into the cyst. So the Intra-Cystic therapy has a long history. This was phosphorus 32, rhenium, yttrium, bleomycin, and the last known drug is interferon. So we also have our own investigation concerning bleomycin, and I can briefly share you the results of this treatment. So this is the cystic cranipharyngioma before and after aspiration. So first of all, we need the implantation of the Omer reservoir into the craniopharyngioma cyst. So it may be performed stereotactic or freehand under the neuronavigation or the ultrasound navigation. So one cyst, one catheter, one reservoir. Sometimes it is possible to perform the two cysts, two catheters in one reservoir, but I don't like this method because you cannot independently treat different cysts. So, and the results of the treatment, these are the supraparacellate cysts, and in 6 months after the treatment, the situation is stable. So this is the again the supraparacellate cyst, giant cyst, you see, and this is in 1.5 years after treatment, and in 2 years after treatment, you see some calcifications, but no progression of a cyst. So, and another case, this the Craniopharyngiomas of the third ventricle, again cystic one, and 1 year after surgery, you see this is the stable disease. So the dynamics of the cyst size in the follow-up period, you may see this is the complete collapse, the decrease in the size with the stable situation, the unchanged situation, and recurrence. So recurrence was about 10%. Very important item, the dynamics of visual functions. And you see, this is in the majority of patients, it was the improvement or stable, and about 10% the deterioration during treatment, and about 10% the deterioration in the follow-up period due to the recurrence. Side effects included nausea, vomiting, dizziness, transient mild fever, skin side effects, but no pulmonary side effects described in some papers. And to the complications, we define as visual disturbances, epileptic seizures, intra-cystic infection, or local brain edema. One patient died. And this is the cumulative Kaplan-Meier survival scheme. So you see, if we perform only the aspirations, the result will be very bad. So nearly all the patients will have the recurrences, but the bleomycin stabilize the size of the cyst, or even completely lead to the complete to the complete shrinkage of the cyst. So, and what we now know about the craniopharyngiomas treatment, about the strategies. So the size of the tumor remnants does not influence the prognosis. So the only one significant factor is the total removal, the gross total removal. The primary surgery has better recurrence-free survival due to more radical removal. The recurrence-free survival of total removal and non-total removal plus radiotherapy are exactly equal. So the degree of radicality does not matter. The results of adjuvant and salvage radiotherapy are similar. The higher radicality, the higher hormone deficit. Due to preservation of the endocrine functions, the following grades of radicality were significant: total, non-total, aspiration. So the hormone deficit increased after surgery to the same extent in all types of tumors, but the initial state is much worse in endosuprasellar tumors. There is a mean deterioration of hormone state after radiation therapy, which was surprising. BMI index as a marker of diencephalic damage is much higher in patients with total surgery. And it depends on localization of a tumor. It is higher in patients with third ventricle and lower in endosuprasellar craniopharyngiomas. The damage effect of radiation therapy appears in 5 years after treatment. And the hazardous effect of visual functions of radiation therapy is minimal. The patients with primary non-total surgery plus radiotherapy has better quality of life. And the intra-cystic therapy is indicated in cystic recurrent tumors. And the final scheme. So perhaps you have seen a very similar scheme, which was published by some of the European investigators in our colleagues in France and in Great Britain, but it slightly differs. We have come to the same conclusions, but we have several different opinions. So first of all, the same as our European colleagues, we differ two groups of craniopharyngiomas with low risk and high risk. The craniopharyngiomas with low risk include the endosuprasellar tumors, suprasellar extraventricular, with no hydrocephalus and no Diencephalic syndrome. So, and the craniopharyngiomas of high risk include third ventricle tumors, patients with hydrocephalus, and Diencephalic syndrome. All these positions are correlated with each other. So, and what is different? So there are papers, again, from our colleagues, from Stéphanie Puget and from Hôpital de l'Enfant de Malade Necker in Paris, concerning the pre-operative estimation of the hypothalamic involvement. As for me, I don't trust the MRI in order to define the hypothalamic involvement. For me, it is much more reliable to estimate the hypothalamic involvement during surgery. So for me, it is very clear when I come to this region to see if these very this very important area of brain is infiltrated or not. So if no, then we may perform the gross total removal of craniopharyngoma, then perform observation, MRI, and in cases of recurrence to perform stereotactic radiotherapy. If yes, if we have the hypothalamic involvement, we should leave some remnants in this place, thus to perform the subtotal removal, and then depending of age, if it is more than 7 years of age, to perform the stereotactic radiotherapy, and then the MRI, follow up with MRI. And in the cases of cystic recurrence, we advocate the intracavitary treatment. Thank you so much.
Okay, thank you very much, Serge. To handle discussion for the last part of this this webinar, I'm going to hand over to Mo El-Beltagi. Mo, you want to see who has any questions?
Thank you, Serge, for this nice presentation and good coverage of the craniopharyngioma and this huge. I just have some comments and questions. First, regarding the beta-catenin. Have you done any beta-catenin for Endoscope craniopharyngiomas, since we have published in July last year 137 cases of children, where we have done for half of them like beta-catenin classification, and it has shown that those with an apparent beta-catenin, 5%, they show aggressive behavior that needs to give radiotherapy even if it is totally resected. Since you can sometimes find a totally resected craniopharyngioma and it recurs, it keeps up coming back. So they don't behave, they are not always similar. Sometimes you remove it subtotal with radiotherapy and you have a good result, as you mentioned, together is totally resected. And so despite the total resection, you have recurrence, either cystic or solid. So looking for the beta-catenin, how these tumors behave at the appearance in the beta-catenin.
Yes,
that's one. And
thank you for this question. It is very important and modern investigation. Yes, we know about this, and I think, as you know, the beta-catenin is related to the adamantoid craniopharyngiomas, which are often revealed in children. And now we perform again our own investigation, more thorough concerning the molecular genetics of craniopharyngiomas. And even perhaps you know that we have published a paper concerning the third gene revealed by our investigations. The BRAF, beta-catenin, and the third gene, which is involved in the progression of the craniopharyngiomas. Unfortunately, we don't know their clinical importance, but nevertheless, I agree with you that investigation of molecular genetics of craniopharyngiomas is very important, and I think it will influence the strategy of craniopharyngoma treatment, not in the future, but in the nearest future, I hope.
Yeah, and the other thing, the gamma knife versus the conventional or stereotactic radiotherapy, as also we find the better control with the stereotactic and conventional radiation than over the gamma knife in the craniopharyngoma. Have you seen something like this with comparing your results of gamma knife to conventional or stereotactic radiation?
Yes, you know, thank you again for this question. We have compared all three methods, except proton therapy, which became available in our country, in Moscow, not far away recently. So we have not revealed any statistically significant advantages of any of these methods. And to compare with proton therapy, I think the same. I haven't. Perhaps we should also compare all these four methods in our clinic. Then I can answer your question. Mm-hmm. But you see, we honestly to say, our radiologists are a bit afraid to perform the gamma knife therapy for craniopharyngiomas due to this very important region. We prefer the cyber knife for craniopharyngoma treatment. But nevertheless, I know very good results for the proton therapy in other papers. And you see, I have answered your question concerning the recurrent-free survival, but it is necessary to compare the acuity of vision and, which is more important, the endocrinological and diencephalic functions. When we shall have, I mean the international society, when we shall have these data statistically significant, then we can answer this question, because the recurrence-free rate, it is not the decision.
And why did you take a 7 years age as a cutoff? Because you said above 7 years. Why not 3 years? Because we usually wait until the growth hormone have done its function, and then we give radiation if we're going to, or give the radiation up. Why 7 years? Because you can give it above 3 years if you're going to give, since the immediate radius is effect being late when recurrence happens.
Thank you. You know, there are different age levels for the radiotherapy. You know, for example, that for anaplastic ependymoma, it's about 1.5 years old in the case of chemotherapy failure. Then for medulloblastoma, it's about 3 to 4 years old. So for the majority of malignant tumors, again, it's about 4 to 5 years old. So, and of course, it is better to wait for the for the when a patient will become to perform, it's better to perform radiotherapy later, as later as possible, in order to preserve the endocrine functions to the extent when it is possible. So this is these 7 years. We usually use this age, but it is not strictly established. You see, the general question, the later as possible, I could answer.
Yeah, okay, I agree. Yeah. So, Dr. Qureshi and Dr. Nasser, any questions?
Yes, I think it's been a brilliant management lecture. One of the dilemmas that parents always come to us with is, how do we stop this child from growing? Are there any known strategies that we can advise the parent on? Well, obviously, we tell them about exercise and we tell them about diet, but every time they come in for the clinic, they go straight to our weighing machine and show us that they have increased by another 5 or 8 kilos. So what are your strategies for advising on the management of this difficult problem of weight gain or increase in BMI? Any particular known workable strategies that you have offered these parents for their children?
I think that this is the most important question in the cranipharyngioma treatment. And you see, during many years, we advocated the radical removal of the tumors. And because there were no other possibilities, I mean the stereotactic radiotherapy and radiosurgery, and in the majority of these cases, there was the weight gain and many other diencephalic disturbances. And this was the reason to perform our investigations. And now we have come to the position, to preserve the diencephalic region as possible. And this is our strategy. If we see the adherence of the tumor to the hypothalamus, to the diencephalic region, we stop the removal of the tumor. Perhaps for our young neurosurgeons, I want to say that it is much easier to perform the gross total removal of cranipharyngioma than to perform the subtotal removal with the remnants, especially in the diencephalic regions. It does not mean that we have not seen or we have left some remnants otherwise in this region. We have to left small regions just near the hypothalamus. This is the only one way to preserve the diencephalic functions. And I want to stress one more. This is not the hormonal insufficiency. Unfortunately, there are no replacement therapy for the to replace the diencephalic functions. There are two different situations.
Thank you. Thank you.
Can I just do a short
Yes,
comment?
please.
Okay. First of all, thank you, Sergey, for this great lecture, and I enjoyed that discussion really. And I know that Mohammed is doing a great job while dealing with these patients, and he gave an outstanding lecture in one of our webinars organized by Egyptian Society and CANS before. And actually, we have two pediatric hospitals. We consider them to be the biggest pediatric hospitals in Egypt, the Japanese hospital, which is affiliated to Cairo University, and 57 hospital at which Mohammed operates. And we are seeing and operating many of these children every year. We have a very, very, very huge material of patients in these two hospitals, in another centers as well. I would like just to inquire about 2 or 3 points. Sergey, do you have any experience about operating in craniopharyngiomas in adults or only in children?
Yes, I'm the head of the pediatric department.
Okay.
Right, yes, I do.
Okay, and I have seen that it was a very good percentage of total removal, 40%, and that's very good percentage. Really, I'm asking for how long were you able to follow up your patients?
In this investigation, we analyzed patients from the beginning of this century, so it's about 20 years.
That's a very long time, yeah. And that's considered to be long-term follow-up duration. And of course, when we operate on craniopharyngiomas, our aim is total removal. In your experience, do you depend on any tools, intra-operative or only the surgical microscope, in order to achieve such goal? And at the same time, what prevents you from doing total removal in some of your patients? Just we need to know your experience while dealing with these patients.
You see, honestly to say that the gross total removal was due mainly to the endosuprasellar and suprasellar extraventricular tumors. So because for the intraventricular tumors with the involvement of the hypothalamus, we intentionally performed the subtotal removal. Sorry, that another question.
I'm asking, do you depend on any other equipment like? Okay.
Sorry about the methods. So I can tell you that we really have one additional method. I mean the endoscope-assisted microsurgery. And I have a nice lecture especially devoted to the endoscopic assistant microsurgery. If Mohammed will invite me, I will share my experience with great pleasure. So, and it is really, so the usage of the endoscope with the angled optics permits to look around the corner, to look in those parts of the operating field which is invisible by the straight view of the operating microscope. And that's why we may extend our removal, to extend the number of patients with the gross total removal. But nevertheless, the main barrier is the involvement of the hypothalamic region. But endoscope really permits to perform the removal more radical.
And so it depends mainly on the microscope. And do you think that the endoscope is beneficial in some patients?
Yes, simultaneous.
You are using both of them together usually?
Yeah, not in the majority of cases. You see, in the beginning of any method, when any method appears in the experience of particular neurosurgeons or in the history, there is a great enthusiasm in the usage of any new method. So in the beginning, we used the endoscope assistance in all our cases. But then we have elaborated indications for the usage of these methods, and now we use it in about 30% of our surgery.
Okay. Thank you.
So Graham wants to comment. I think he has a comment. Graham.
Hey, Mohammed. Yeah. So firstly, thank you very much to Serge. You not just have these enormous volumes in Moscow. You're clearly one of the real thinkers and philosophers in pediatric neurosurgery, and I really love listening to your talks. You always approach things often in a very creative sort of way, and I think you've made a really important point in emphasizing what a subtotal removal actually is, and And I think it's easy for people to be sort of misguided into thinking that a subtotal removal is having a crack at doing a total removal and sort of bailing out because you're in trouble and calling that a subtotal removal. And as you've said, it's an intentional treatment strategy that you start off with. And I think for most neurosurgeons, one of the most satisfying things you can do is to do a total removal. And that amazing view when you look at the circle of Willis and the basilar artery and you've taken everything out, it looks great. But when you follow those kids up, they seldom look so great. And I think if you reflect on Dackling Pang's words, and Dackling was one of the strongest advocates for total removal, and he wrote many years ago that the typical kid with a cranio is short, fat, half-blind with a poor school record, and that's exactly because of the hypothalamic damage that you spoke about. And you can avoid that in a lot of kids. So I really, really appreciate the way you emphasize that. I think the other thing I want to really pick up on is the value of intra-cystic treatment. And I think particularly for colleagues in less resourced areas who are part of this webinar, if you don't have the capacity to provide the endocrine support, which is sadly the case in many low middle income countries, it's really, really important that you do everything you can to preserve hypothalamic and endocrine function. And in that situation, doing a less invasive procedure, putting a catheter in, using intracystic therapy, obviously interferon is not necessarily available in poorer countries. But those kinds of strategies, I think, enable you to have a kid who's going to be a lot more functional in the long term. And, tailoring your treatment intervention to resources you have available to support the kid is going to be very important. So thanks, Serge. That was a really great talk. And for people on this webinar who may not be familiar with the ISBN, all our moderators and the speakers are all members of the ISBN. And there's really fantastic educational material available on the ISBN website. So if you have a look at that, look at the guide. There's some really great resources that you can tap into. So thanks, Mohammed. Thank you, Leland. It was really great. And I really appreciate being invited to be part of this.
And I want to stress that it's a great pleasure for me to discuss with Mohammed the treatment of craniopharyngiomas, which we perform at every meeting all over the world. Really, your center is the greatest center for the treatment of craniopharyngiomas, I think, in the world. And it's a great pleasure. We have many similar approaches for the strategy. And thank you once more, Mohammed, for invitation and the possibility once more to discuss our approaches to this very difficult
Thank you, Sergey, for this experience. I just want to ask if anyone from the floor wants to comment or have a question, just unmute or send on the chat. Okay, the only question
I
think
is if it is possible to view the recording.
Yes. Yeah, we will look for this. Not yet. Okay, so Levon, comments or wrap up? Yes.
Yeah, thanks, man. I think those were just sort of spectacular talks, and thanks to both Wenqiu and Sergey for really contributing to the level of excellence.
Excuse me, would you allow me to do an announcement before you close?
Sure. Let me